Dr. Farnaz. She'll be presenting of optic nerve meningioma and glioma, a clinical radiological diagnosis.
Hi, hello, and a very good morning. I'm Dr. Farnaz, and we'll be discussing on optic nerve glioma and optic nerve sheath meningioma. Are these tumors a clinical radiological diagnosis? So optic nerve gliomas are relatively rare lesions which comprise about 1% of the intracranial tumors, still the most common optic nerve tumor, whereas optic nerve sheath meningiomas constitute about 1% of meningiomas, second most common optic nerve tumor after gliomas. Still, why is this considered as a diagnostic difficulty? First reason being the rarity of the disease, and then because of all the reasons listed on the left side of your screen. Ours was a retrospective study where we analyzed 36 optic nerve tumors, 15 gliomas and 21 meningiomas for the following as given on your screen. The mean age was 15 years among the glioma patients and 53% were males. And 43 years was the mean age in the meningioma group and 57% were females. The main clinical features were protrusion of the eye, diminution of vision, strabismus, extraocular movement restriction, and disc changes included a normal disc, mild pallor of the disc, severe disc pallor, hyperemia with choroidal folds and optociliary shunts as well. The mean duration of symptoms among the glioma patients was 52 months and 73 months among the meningioma patients, with most of them having protrusion and diminution of vision. The appropriate imaging for these tumors is MRI brain with orbits with contrast enhancement. On the left side, glioma shows enlargement of the nerve itself, hypointense on T1. However, a soft tissue mass along the optic nerve sheath on your right side, hypointense on T1, is suggestive of meningioma. In T2 weighted images, glioma displays high signal intensity and is definitely hyperintense, whereas a meningioma is either iso to hypointense. Contrast enhancement is seen in both, but gliomas are usually irregular and botchy, whereas meningiomas regular, circumferential enhancement with centrally non-enhancing optic nerve. The treatment strategies for gliomas, in our series, chemotherapy was given in 7%, usually for children under 3 years of age group, until they get fit for radiation therapy, and 67% received radiation. Among the meningioma patients, the widely used treatment strategy was stereotactic radiation, almost done in 95%, with incisional biopsy and debulking required only in few ambiguous cases when there is disfiguring proptosis. EBRT, how is it done in such cases? First, the T1 weighted axial and coronal images are registered with a gadolinium enhancement are registered with a planning CT. The gross tumor volume is defined as the area of contrast enhancement, and this, when expanded by 1 centimeter in all directions, gives you the planning target volume. The target specific gradient of radiation therapy. So first, the area of the tumor, which is the area of interest as marked in the first image, receives 95% of the prescribed dose of radiation, followed by the second image showing the surrounding area, which receives 50% of the remaining radiation, and the third image shows 20% of prescribed dose of radiation, and thereby preventing collateral damage. So these are our pre-op and post-op patients who had excellent improvement in vision or stability of vision with significant resolution of the strabismus as well and the tumor size as well. For meningioma, the pre-EBRT and post-EBRT images show resolution of proptosis and improvement of vision with reduction in the meningioma size as well. So our study stands out from others in a way that both the optic nerve gliomas and meningiomas were analyzed. Diminution of vision and proptosis were the main clinical features, and MRI brain with orbits and contrast enhancement was done in 100% of patients, and also neuroprotective EBRT was the mainstay of treatment. So to conclude, gliomas and meningiomas can be diagnosed clinico-radiologically, thereby restricting surgical intervention only to cases of disfiguring proptosis and intracranial extension. So early diagnosis with fundus examination, requesting the correct MRI, precision reporting, easier access to neuro-ophthalmologists or ocular oncologists, timely and etiology-based treatment with EBRT thereby leads to better visual outcome and stability. Thanks a lot.
Very nicely presented and very clinical features they were demarcated. Very nice presentation, Dr.
Thank you, ma'am.